Good morning. Thank you so much for joining us today for our third day of legislative seminar. This morning, we're going to be learning about the policies related to drug use and the overdose crisis in North Carolina. My name is Elizabeth Brewington, and I am the Overdose Response Program Coordinator for the North Carolina Council of Churches. My pronouns are she, her, and hers, and I currently reside in Durham on the unceded lands of the Shakori, Eno, and Tuscarora people. Please feel free to introduce yourself in the chat and let us know where you're joining from. So through our Partners in Health and Wholeness program, we began working in the opioid crisis about 3 years ago after hearing about the impact on congregations and communities from our faith partners across the state. At that time, 6 people a day were dying due to an unintentional drug or medication overdose in North Carolina. Since that time, I've traveled to over 24 towns and cities from the mountains to the coast and held conversations with faith leaders, laypersons, community leaders, and people with lived experience. This is a complicated public health issue that is often treated with moral failure and met with increasingly punitive measures. We believe the church can be instrumental in reducing the shame and stigma attached to God's children who use drugs and can make a real difference about bringing about healing. We also believe it's our mandate to advocate for justice and policies around drug use and reduce deaths by overdose. In fact, we have seen many of these things happen already, and one of our favorite people that we have met along our way is our presenter today, the Reverend Minister Michelle Mathis. Oh my goodness, y'all, I have not had enough coffee this morning. So sorry. The Reverend Minister Michelle Mathis is the Executive Director of Olive Branch Ministry, a faith-based harm reduction agency serving in the Foothills, Piedmont region of North Carolina. She oversees a Tri-County Overdose Response Team and Points of Hope, a justice-centered education and syringe service program that includes low barrier and low threshold suboxone and HepC treatment. Michelle is the board president of the North Carolina Harm Reduction Coalition and serves on the National Faith and Harm Reduction movement. She believes in honoring an individual's journey with compassion and love is the key to a successful connection. While her faith is the motivation behind her work, extending hope and extending life is her mission. Please welcome Michelle.
Good morning. It is wonderful for really just to be here with you this morning. I love working with the North Carolina Council of Churches and sharing the gospel of harm reduction. I bring to you this morning not so much a message of hope, which I usually try to present, but today we have some concerns around current legislation that's being proposed in North Carolina. So I'd like to give you a brief kind of history for those of you who are not familiar with legislation surrounding the harm reduction and syringe access programs here in North Carolina. And then we'll talk about the proposed legislation and have a call to action at the end. I'm going to share my screen, and I always kind of cross my fingers and say all my prayers to see if this is going to work. So let's see. All right, are you able to see that? Yes? Okay, awesome. And I'm gonna leave it in this format so that way I can still see all your faces if you have questions. So a brief history about syringe access laws in North Carolina. In 2013, House Bill 850 was passed, and that allowed for possession of needle and the tell officers law. It became effective December 1st of 2013, and it says that if a person alerts an officer to the fact that he or she has a hypodermic needle or other sharp object on her person, on the premises or in the vehicle, and if they designate that prior to a search, they can't be charged or prosecuted with the possession of drug paraphernalia for that object. The purpose of the law is to protect officers from puncture wounds, from sharp objects that could potentially be contaminated with HIV or hepatitis C. And it encourages suspects to be honest with officers about paraphernalia that they may have in their possession. You can buy syringes at pharmacies in North Carolina, but the pharmacist can decide not to sell them to you. Now I'm jumping right into the legislation, right? Normally we have some kind of flowery introduction and I'll tell you all the loveliness, but legislation is pretty cut and dried. What we need to understand, and I'm sure everyone on the call does, is that first, our vote matters, right? And so the people that we elect to go to Raleigh to pass these laws, to write these laws, they are not our leaders. They're there to represent us. And these laws are that I'm going to go over that we have had enacted are wonderful. But I just want you to keep that in mind, that the folks that are proposing the new legislation that will essentially, if enacted, destroy the majority of what I'm getting ready to tell you from historical purposes, that they represent you. And so I'm going to encourage you as we go through this and progress in the broader application of these laws, that it's important that your representatives know how you want them to represent you. In 2015, we had House Bill 712. And Governor McCrory signed that, which was the pilot project used needle disposal bill. This was wonderful because it states that anyone who declares that they have a syringe or a sharp object to law enforcement prior to search can't be charged. But then also HB 712 authorized 4 North Carolina counties, Brunswick, Guilford, Cumberland, and Haywood, to establish pilot programs to collect and safely dispose of used syringes in their communities. This was super, super important. That didn't mean that we could distribute them at that point, but at least that we could begin to do legal collection and disposal. The North Carolina Harm Reduction started those projects in those 4 counties on December 1st of 2015. Then in 2016, on July 11th, which I actually celebrate this day every year. My birthday's July 6th. And then 5 days later, I get to have another birthday. And it's the birthday of the Syringe Exchange Law in North Carolina. I will never forget that day. I may forget my anniversary, but I'm not going to forget this day. Syringe exchange became legal July 11th, 2016. And the syringe exchange programs collect used syringes from people who inject drugs and exchange them. And it's not really an exchange because you don't have to give dirty syringes in order to receive clean ones, but we allow access to sterile syringes. And we make linkage to care to social services, including substance use treatment if someone wants that. House Bill 972 also regulated the release of law enforcement body camera footage. And it's important to note this because North Carolina Harm Reduction did not participate in the drafting of that section of the bill, but this is a prime example of how sometimes one bill gets piggybacked onto another to get them both to pass. According to the general statutes, no employee, volunteer, or participant of a syringe exchange can be charged with possession of syringes or other injection supplies without residual amounts of controlled substances in them, obtained from or returned to a syringe exchange. Syringe exchange programs supply a card that a letter or documentation to each participant stating they obtained their clean injection supplies from the exchange. That's super, super important. And if I'd been prepared, I would have shown you a copy of my card. But we use business card size cards, and it has a copy of the general statute on there. It has a unique identifier for each participant and the date that they enrolled into our program. Super important because they can then present that card to law enforcement or present it in court that says I was a member of the syringe exchange on this date. And so charges and prosecution do not apply for safe injection equipment that they receive from the exchange. Oftentimes we will have law enforcement that tear up the cards that say the cards are not legitimate. And then we have to issue letters to the court, or we actually go to court with folks to verify that they were indeed participants in our program at the time of arrest. So although we have the law in place, it's not always followed by law enforcement. In 2017, which was our next big hurrah for harm reduction legislation in North Carolina, we had the STOP Act. The STOP Act underscores that no state funds may be used to support needle exchange programs, but it does not preclude a local government from supporting a program in its community. Now, this was obviously directed at harm reduction. However, there were a lot of good things that came out of the STOP Act. It helped regulate the amount of opioids that were prescribed. It set up a network so doctors could see, so they weren't over prescribing for a particular individual. And many people see that as a very good thing. But what it did was it also opened up local communities to be able to say, you know what, I know you can't get state funds for your local programs, but we're going to give you as a local municipality funds for this. Now, I'm not going to ask how many local municipalities did that because I serve in 10 counties and none of ours did that. So it was kind of a lip service effort to say local government can support syringe exchange if they want to. We know that the state wants to be able to give funds, and some of those things are changing, but this particular law in 2017 made it a little bit more difficult for the state to support syringe access programs in a way that was effective, which is essentially paying for syringes. So that's kind of where we are. Very brief history of the syringe access laws and things that have affected syringe access. Before this started happening, before we started having legislation, syringe exchange was alive and well in North Carolina. My own agency, Olive Branch, participated in it for about 3.5 or 4 years before it became legal. Many agencies were doing it for a decade or more before we even got started in the game. And we all did that at the risk of charge and prosecution. There were many folks that were charged and prosecuted and spent jail time participating in syringe access. Some of those individuals were people of faith who were arrested because they were running underground syringe exchange in their fellowship halls. And we did that because we believe in the good of syringe access, and we know that it reduces disease and that empowers people to take control over their health journeys. So laws are important, and there are just laws, and then there are unjust laws, and we're getting ready to talk about one that is being proposed right now. We have on the books something that's actually floating through committee in the North Carolina Senate, and it's Senate Bill 607. And I'm going to go through this in great detail because I think it's important for those that are on the Zoom call today to understand exactly how sometimes this legislation can work, where it doesn't say we want to get rid of syringe access, but everything in the bill does everything in its power to actually get rid of these other laws that have been enacted. Senate Bill 607 would require programs, syringe access programs, to be co-located in a building that offers professional counseling or rehabilitation services, and also require participants to enroll in evidence-based treatment. Now, when they say evidence-based treatment, they mean abstinence-based treatment. They do not mean harm reduction. We know that harm reduction is evidence-based treatment. This would not be best practice. Syringe access programs offer many opportunities for positive change beyond drug treatment, including disease prevention, wound care, health education, overdose prevention, and we do a lot of linkage to care to abstinence-based treatments for those individuals who want to get enrolled in that. It makes abstinence-based treatment a precondition to access, and it would deny many participants the benefits of what a syringe access program does. On top of all of that, there's a severe shortage of abstinence-based treatment programs in North Carolina. DHHS estimates that 89% of people can't even get into treatment if they need it. Sometimes that's due to lack of transportation. Many times it's due to lack of funding or lack of availability, even for, especially for residential rehabilitation, or even outpatient services. There's just not enough services to treat everyone. So having syringe access programs that are harm reduction based allows people to stay in the continuum of care, and work on their health, and work on their substance use in a way that they dictate, but a way that helps keep them alive as long as possible and healthy as long as possible until they make that decision if they want to. And it should be autonomous. They should be able to make the decision of whether or not they want to enter into an abstinence-based treatment. 607 also would require programs to ensure that all program supplies are engraved or marked with a symbol or logo that clearly identifies the program. And I have to laugh at this because can you imagine, we have a sterile pack of syringes that we're giving to someone, and we have to open up the pack and take an engraver, like a Dremel, and actually engrave each syringe. You violated the sterility of the product, and there's just absolutely no way to do that if you think about the fact that sometimes we give anywhere from 60 to 100 syringes at a time. And we may see, some exchanges see over 30 people a day. So that's just not possible. It's impractical, it's unhygienic. The supplies that we hand out are sterile, and we go to great lengths to make sure that they stay sterile. And so that is just a problem. And it tells you that the individuals who drew up this law either don't understand what we do, which is the case, but they're also trying to make the conditions so stringent that we can't do our jobs. We can't operate a syringe access program. Senate Bill 607 would require syringe access programs to operate outside of a 3-mile radius of a school zone and to get approval from the majority of neighborhood residents, with more than 50% of residents attending a meeting. Y'all, we're still in COVID. You can't get 50% of the residents of a neighborhood to show up for rezoning at City Hall. You're not going to get 50% of residents to show up at a meeting to talk about syringe access. Maybe if we served, had a fellowship meal afterwards, folks would show, but you're still not going to get 50%, right? It's just not possible. This is trying to make it more difficult for syringe access programs to find fixed site locations. The counties that I operate in, all but one are considered rural or have a majority rural areas. And trying to get folks out to talk about that in a rural community, again, would be impossible. It's important to note that people who use drugs are not pariahs, but they're members of our communities and their families. And the programs work best when the participants don't have to travel long distances to reach them. So this would, in effect, if you think about the smaller communities where the school may be located in the center of town, this would put an SSP on the outskirts of town, or maybe even outside of a city limit. Research shows that even requiring like 1,000-foot buffer zone around schools in one city made the majority of land space ineligible for SSPs. Senate Bill 607 would require programs to operate out of a fixed location. Again, this is a problem for rural North Carolina. When I tell you that there is one particular family that we deliver to that I literally have to drive through a cow pasture to get to a mobile home that's kind of back in the woods with no electricity to reach folks, that's legit. That's very true. Okay. And so those individuals do not have transportation. They are not employed. They have a very difficult time even finding groceries and getting somebody to bring food to them. So having them try to come to our SSP is impossible for them. We also know that meeting people where they are, not only emotionally and spiritually, but physically going to where they are, for many folks is the best chance of success in getting them engaged in this life-saving program. More than half the counties currently served would have no program at all if mobile services were disallowed. The burden, again, would fall on the rural communities. In Cleveland County, we have a fixed site, but the majority of our exchange takes place mobily because we also serve Rutherford County out of that, and on occasion, McDowell County out of that. So there's no one from McDowell or Rutherford County that can come all the way down to public health in Cleveland County to access our services. The proposed legislation says that people running SSPs cannot have felony convictions or pleas of any kind of misdemeanor convictions or pleas for drug offenses. We know that the most effective SSPs are run by people with lived experience, right? The majority of SSPs have people that have lived experience with drug use. They've walked the walk, they've talked the talk, and they can build effective relationships with people who are currently living the experience. It helps programs reach out or reach what other professionals consider a hard to reach population, right? Because we're relatable. People that run SSPs are relatable to the individuals that we serve. Because we're in the midst of a drug war, many people with experience of drug use also have a criminal record, whether a felony or a misdemeanor. So by eliminating the possibility to have people who have criminal backgrounds in leadership in SSPs, the majority of SSPs in the state would have to close. This would require programs in non-commercial areas to request an ID from participants in order to check whether or not they are sex offenders. We currently operate syringe access program with the option of anonymity. We do not ask for identification. Someone can come in and sign up as John Doe if they want to, or not give a name at all. Given the deep stigma that's still associated with drug use and the fact that it's a criminalized behavior, it's the best practice for programs to offer anonymous services without the requirement for IDs. On top of that, many of our folks are housing challenged, or they operate and live in a community where theft is the norm. And so their IDs are stolen, or they're traded, or they're sold. So requiring someone to have an ID is ineffective. There are no documented cases of problems caused by people on sex offender registries being in neighborhoods for harm reduction services. Such a requirement would needlessly deter many people from seeking life-saving services while doing little to actually improve public safety. The bill would require programs to purchase both general liability insurance and professional liability insurance in the amount of $1 million each, with any lapse in coverage being grounds for immediate termination of the program. This requirement would be cost prohibitive for most North Carolina syringe access programs, and it seems intended to sabotage the program's ability to exist. Now, I will tell you that Olive Branch has been a nonprofit since 2015. It took us until 2019 to achieve this level of professional and general liability insurance because of the nature of the work that we do. It wasn't that we weren't eligible, we couldn't find anyone to cover us. And we often get questions as SAPs at the state level for North Carolina Harm Reduction Coalition of what liability companies will cover a syringe access program. And we get that question actually from other states as well. It's very, very difficult because of the work that we do with the population that we serve and the medication that we handle, which is Naloxone, the medication that reverses an opiate overdose. It's very difficult to find liability insurance that will cover us, especially at that amount. And it's very expensive. So it would be cost prohibitive for smaller community-based organizations who are running syringe access programs to be able to afford that type of insurance. Every one of these things that I've listed are written and designed to shut down syringe access programs in North Carolina. But I want to talk to you for a minute about the public health effectiveness of syringe access programs. The evidence is conclusive that syringe access programs decrease injection-related disease transmission risk, including HIV and viral hepatitis, without increasing drug use. Studies have repeatedly shown that they do not increase negative consequences like improperly discarded syringes or crime. North Carolina SAPs are leading distributors of Naloxone, which I just mentioned, the antidote for opioid overdose. And according to DHHS, in the 2019-2020 reporting year, Syringe Exchanges distributed more than 53,000 doses of Naloxone and recorded more than 8,600 overdose reversals. That's 8,600 second and third and fourth chances. That's 8,600 lives that were saved because of syringe access programs being able to distribute Naloxone. And it's important to note that that 53,000 doses of Naloxone did not include doses from EMS, doses from public health, doses from law enforcement, doses from hospitals. That was simply at that time, I think 37 syringe access programs that we have in North Carolina distributed that much Naloxone. There's a cost effectiveness as well associated with syringe access. They save communities enormous amount of money in treating HIV and HCV infections, overdose, and issues like endocarditis. A 2014 economic evaluation of syringe access programs expansion found that each dollar invested in an SSP would save between about $7.50 in HIV treatment. So when you think about the numbers of dollars that are invested, that's huge. The way that I look at this, right, is that my syringe access, and I can speak for my syringe access program, but my syringe access program participates in a free HepC treatment program. That medication runs $27,000 a month, and you're required to have 2 months. If I can prevent someone from contracting HCV, I've saved that money, right? And my syringe kit that I give out to someone costs anywhere from $17 to $30. So if you look at that $17 to $30 to keep someone from sharing syringes and contracting HCV versus 2 months of $27,000 worth of treatment, that's a huge savings right there, right? And we work with the FQHC, the federally qualified health clinic in our area, to be able to give out that medication. They run the clinical side of things. But if you look at a lifetime treatment for HIV or a valve replacement due to endocarditis that's caused by sepsis from improperly cared for wounds and infections caught through injecting drugs, a $17 to $30 kit is nothing compared to the cost of that. It's hugely cost effective. Not only that, it allows people, as they begin to take those positive changes, to be able to sometimes return to work, right? So there's a lesser burden on other social services because they're able to then support themselves in the community. The 2015 HIV outbreak in Scott County, Indiana, culminated in 185 new cases. The cost of treating the resulting HIV and viral hepatitis cases are 487 times the annual cost of operating an SSP that could have prevented these cases. So what would be the consequences of closing an SSP? Over the past 2 decades, HIV transmission has generally declined among people who inject drugs, but spikes in new HIV diagnoses among people who inject drugs coincides with communities that lack SSPs. Closing SSPs does not reduce publicly discarded, does not reduce publicly discarded syringes and other supplies. So I want to stop and ask if there's any brief questions, and then we're going to watch a video, and then we'll come back with a call to action. That was a lot of information in 30 minutes, I realize that. And if there's anything in the chat, I cannot see the chat right now.
Any questions come through in the chat, I will
Okay.
raise them for you, but so far I don't see any.
All right. Okay, well, I'm going to then bring up a video that I would like for you to watch that talks about the effectiveness of extending hope and extending life through SSPs. This video was shot at the request of the North Carolina AIDS Action Network. It happens to feature Olive Branch, but I would have shown it no matter who it was, because I think it's really important, and we're going to use this video in combating SB 607. Can you see the video?
Yes, could you put it in full screen?
Yes. There we go. All right.
All right, I can't hear the video. Is there a button on your screen share that says optimize for video?
Let me see. Hold on. I might need you to pull that up, Elizabeth, if I can't get it pulled up.
Can do.
Oh, optimize for video clip. Let's try that.
Perfect.
Okay.
The presence of syringe service programs in West North Carolina is essential, and that's thanks to the Syringe Service Law, and it allows for the treatment of undiagnosed hepatitis C and the preventing of unnecessary deaths due to untreated hepatitis C and reversible overdoses.
Olive Branch Ministry is a faith-based harm reduction agency that serves the Foothills and Piedmont area of North Carolina. We provide harm reduction services like syringe access programs, naloxone distribution, and overdose prevention.
I used to be a drug user myself, and if I had them services back in the day, I probably wouldn't have used mud puddle water, dirty rigs, or I would have clean supplies, clean water, and I would also have the support system behind me to walk the line with me to help me get clean.
They offer programs to benefit, like to help you get off of stuff, and they give somebody to talk to and counseling with people and stuff like that.
The difference between before we found the syringe program and now is that we're a lot safer about the way that we do use syringes. We do have someone to come and talk to if we need anyone to talk to. If we don't have a ride, they're more than welcome to come to us to make sure that we can use clean, that way we're not catching or passing anything.
We also help lighten the burden on the taxpayer, because the services that we provide are extremely cost effective as opposed to seeking treatment for things like endocarditis, which is upwards of $250,000, right? Or a lifetime of HIV medication, maintenance medication. We enable people to build relationships with people that they can trust, where there's not stigma involved. We enable people to extend hope in their own lives and to extend life. And that's the mission of Olive Branch.
It just makes it all around safer and cleaner.
All right, are we back?
Yes.
Okay, there we go. Now I can see people again. So that's a brief video, right? But those are live participants. Those are folks that, a young couple that comes in to see us, and we see them every week. And we've seen a huge change in their confidence to be able to walk into the space, their confidence in being able to talk with us because they know they have a safe environment. They're not judged in our space when they come in. We're there to help them in ways that they ask us to, right? But we're not there to tell them this is what you need. This is what you have to do. You have to choose abstinence-based treatment. We're here to say, we're here, we love you, and we'll walk through this journey with you, whatever that may look like. I think that's important. The other lady featured in the video, her name is Jessica, and she works for us in Gaston County. When I met Jessica, she had on an orange jumpsuit and shackles, and she was a resident of the Cleveland County Jail. And she was in there on drug charges. And she was part of our jail-based education program that we also run through our Syringe Access program. If we didn't have SSPs, Jessica probably would have ended up in prison. But because of the outreach program through our SSP, when she got out, she became a volunteer with us in Cleveland County. And she volunteered with us for about 6 months. And she expressed interest in doing what we did. She fell in love with harm reduction, and she did not return to use after she got out because of what she'd learned while she was on the inside through our education programs. And because she had support through our syringe access staff in Cleveland County. So after about 6 months, by that time, she'd had a significant amount of time not using substances. And she took the peer support program through the state and became a certified peer support specialist. And now she's worked with us for over a year, and she is outstanding at what she does. And it's all because she had access to programming provided by a Syringe Access program in her community. And I'm so proud of her. And I'm so proud of Kendra and Derek, who were also in the video, because they were willing to meet the Syringe Access program where it was, just like the Syringe Access program was willing to meet them where they were. And we've built beautiful relationships because of that. And this SB 607 is set out to destroy programs like ours and so many across the state who have stories like this as well. So now I have a call to action. 2 things specifically. I spoke with Lee Starrow this morning, who is the executive director for North Carolina AIDS Action Network, who's kind of heading up the calls to action along with other syringe access leaders throughout the state. And Lee asked that I present you with 2 calls to action. The first one is that on May 10th, from 4 to 6 at Moore Square on Blunt Street in Raleigh, we are going to have a syringe service speak out. So we'll have leaders from the HepC and syringe access programs there to talk about the importance of SSPs and why we need to preserve them and encourage their growth in the state. And we will have people who are living experience of using SSPs also there to speak. So please write that down on your calendar. And I believe Elizabeth is going to put a link in the chat to show the link to be able to sign up for that if you're available. And then the next call to action is to sign on with the North Carolina AIDS Action Network in opposition to Senate Bill 607, which includes provisions that would implement harmful changes to North Carolina syringe exchange laws. And there's also a link in the chat for that as well. If you want to sign on as an organization, then you can reach out to Christina at ncan.org, and she can talk to you about signing up as an organization and not an individual. But I would encourage you, you can Google SB 607 if you want to see the exact verbiage, but encourage you to take a stand against this legislation, which is really set, if it were to get out of committee at this point, to destroy syringe access programs. We do have some hope, and the hope is that it will not get out of committee. There's been some talks with the primary author of the bill, who has changed his mind on a few things, but he's not pulling the bill back out of committee. So our hope is we have about 2 weeks before this would, if it is not addressed in committee, that it would fall dead and never make it out to the floor for discussion. The other hope is that the deadline for the House to file a companion bill is May 4th, and that's right around the corner. So we have hope that no one from the House will author a companion bill, but we still realize that is a possibility. So that's our legislation update. I hope that you've learned a little bit about the history of syringe access and the fight that we've had to get where we are today, the great work that we're doing as syringe access programs. I hope you've learned more about Senate Bill 607 if you had not heard about that already, and the potential for the destructiveness that it has. And then I hope with the video that you were able to catch just a couple of minutes glimpse of the real life impact that syringe access programs have on individuals who use drugs here in North Carolina. I'm happy to answer any questions that you may have, or hear any discussion that you may have, or any thoughts that you may have that you would like for us to take back to the leaders who are actively combating this legislation right now.
Thank you, Michelle. Let's see. So the first question I have for you are, what are some non-legislative ways that people can get involved and support SSPs?
I'm so glad you asked. There are many different ways that organizations can get involved. In fact, we have a whole presentation that we do through the North Carolina Council of Churches that Elizabeth mentioned in the very beginning, that has a menu of ideas. Things from doing things like medication take back, right, as harm reduction in your community, or we have a program called Hookin' for Hope, which makes little crocheted bags to put in life-saving Narcan and Naloxone kits so that individuals can find them. It has a reflective thread in there, so individuals can find them when they don't have access to electric light. You can participate by having wound care supply drives, or hosting non-traditional support groups, perhaps a Medication Assisted Recovery Anonymous or Harm Reduction Works program at your location. For us, we're fortunate that a church reached out to us because we had 2 offices in counties where we didn't live. We'd been operating for years in our own county, but you know, they say a prophet's not welcome in his own city, right? And so we weren't necessarily welcome in the city that we live in. But we had a church that heard us after one of the talks that we did with the Council of Churches, and they offered us space. And so now we partner with Northminster Presbyterian Church here in Hickory and have a beautiful space, and are so thankful for that partnership. So that might be a possibility. There's a lot of different ways that you can partner. And if you want to check out our website, olivebranchministry.org, we also list ways that you can participate and support SSPs in that way.
Well, kind of going off that answer, what is your experience communicating your message of harm reduction and SSPs to faith communities, and how responsive or resistant have they been?
Overwhelmingly, folks are responsive, right? Many times there are congregations or faith groups that want to do something. They just don't know what that what is. And so having an opportunity to talk with them about, as harm reductionists, we demand that people meet us where we are, right? But we also have to be willing to meet people where they are, and that includes the faith community. And that's one of the things that I emphasize in the talks that we do, is that not every congregation is going to be willing to run a syringe exchange, and that's okay, right? But there are things that can be involved with, right? Offering a church van with a volunteer from the church to be able to take folks to court dates or to community appointments that have to do with their substance use disorder. That's one way to get folks involved. There's a lot of different ways. And being able to communicate that with faith leaders, sometimes you see the light bulbs go on. But as Elizabeth and Chris both know, I also have been told that I'm condemning people's souls to hell because I'm putting a syringe in their hand. And you know what? I still have to meet that colleague who is a friend of mine where he is, and continue to work with him and communicate with him, right? You can't shut down communications because someone disagrees with you. But overwhelmingly, I find that people are supportive. They're just looking for a what to be able to do. And one of the things that I do say with Olive Branch is that our faith is our why. It is not our what. So we don't evangelize. We don't require people to convert to a particular theology. We don't require them to attend a Bible study or a sermon before we feed them soup. We just love people, right? That's all we do.
So going off that, what in your mind is the best way to combat stigma around drug use in a way that allows us to have community conversations and move towards action that truly loves our neighbors?
Talk about it, talk about it, talk about it. Hey, right? Isn't that how the song goes? I'm not a singer, but that's it. We got to talk about it. We got to be willing to talk about it. We got to be willing to have conversations. We got to have faith leaders that stand up and say that we have an overdose crisis. It's not an opioid crisis, right? It's an overdose crisis. And we have that in our community. And we realize that there are people in our communities, people in our congregations that are affected by the overdose crisis. And this may not, as a church, may not have always been the safest place to discuss this, but we're going to change that, right? We have, through Faith and Harm Reduction, a toolkit that helps congregations work through what might work best for them. It provides liturgy, it provides song suggestion, it provides prayers, it provides different types of ceremonies. One that Chris mentions often is a naming ceremony, right? Which allows people just to simply to lift up names of folks they know who have been impacted by the overdose crisis. They may have lost someone, or they may have in other ways. And so all of that is combined in this beautiful toolkit that the National Faith and Harm Reduction Coalition has put together. And that's available to folks online.
Thank you. And the toolkit I put in the chat, and Sarah, thank you for sharing the Faith and Harm Reduction website as well. So shifting gears a little bit and moving outside of North Carolina, do you know what research is being done in Oregon as to the shifts due to the decriminalization of drug use? I know it's early days, but curious.
Yeah, I don't know that yet because it is so early, but we can look to Portugal, and I think we will see similar results. probably not on as large of scale because Oregon's much smaller and much newer in this, but we know that it's worked in Portugal, right? And I have faith that it's going to work in Oregon too. And then hopefully we'll begin to see that take place in other states.
Thank you. All righty, let's see. And feel free to keep putting questions in the chat. We're more than welcome to keep going. What do you feel is the best way for community members to be allies, and how can we prevent overdose as community members?
Host overdose prevention trainings. Allow folks to come in and to train on harm reduction 101 and overdose prevention. Support the distribution of naloxone in your community and Narcan. If you have an SSP in your area, one of the biggest requests, we have two biggest requests. One is for syringes, the other is for naloxone. And there's not always funding available for that. So holding fundraisers for that would be super helpful. Carrying naloxone yourself and knowing how to use it is very important as well. And then working with other local groups to make sure that they're aware. Things like Rotaries, civic clubs, making sure that it's available, that naloxone or Narcan is available to churches in your area and that the staff knows how to use it is super important.
And my colleague Sarah asked, who offers naloxone trainings?
So the SSPs in your area, North Carolina Harm Reduction Coalition offers it. We do as part of training through North Carolina Council of Churches. And sometimes EMS will do that as well, but mainly it's harm reduction agencies. You can get a list of harm reduction agencies both at nchrc.org, and you can reach out to local syringe access programs, which are listed on the DHHS website.
Thank you. And that's all the questions I have. So last chance to get your questions in. All right. Thank you for everyone putting in the chat that they have signed on to the letter. That is wonderful.
Thank you so much.
We really want to defeat this bill before it goes anywhere. Thank you, Michelle. Thank you so much for being here and presenting and doing the work you do. We so appreciate it.
Thank you for the opportunity, and shout out to both Chris and Sarah, who, along with Elizabeth, encourage this conversation between faith and harm reduction on a daily basis. We're in this together, right? We all have a part to play. So thank you very much.
We are now going to turn to our closing liturgy. All right. God of peace, you have shown yourself to us as one who has demonstrated what true power looks like by refusing to use violence. We are willing to follow your way of peace. God of justice, you have invited us into peacemaking work by showing us that justice is the first ingredient. We are willing to work for your way of justice. God of righteousness, you have provided the means for all creation to flourish when we walk your righteous path. We are willing to be your righteous people. Amen. Thank you all so much for being here today, participating and engaging with this work. We look forward to seeing you this afternoon for our 1 o'clock call, and hopefully later on in the week as our seminar wraps up and continues. Thank you so much. Have a good day.